Myself, Dr. JIBRAN Ahmad presents to you Simply Pathology, and today we are back with an important lecture. So this is a very important topic, and it is a very commonly asked question in the exams. Okay, not only in your theory paper but also in the practicals. Okay, so the question goes: enumerate the papillary lesions of the breast and also state the points of differences between each other. Okay, so let us start today's topic of discussion without wasting any more time. Okay. So what are the papillary lesions of the breast? Okay, so they are intraductal papilloma, papillary ductal carcinoma in situ, encapsulated papillary carcinoma, solid papillary carcinoma both in situ as well as invasive, and invasive papillary carcinoma. Now what is very important that each one is a distinct entity, and and all of them, they are acting as a differential diagnosis for each other. So we have to understand that how we can differentiate each of these entities from each other, not only histologically but also with the help of immunohistochemistry. Okay. So before I start this lecture, I am just going to give you a very brief idea of how to differentiate each one of them on the basis of immunohistochemistry. For that, I would just like to tell you, or just like to enumerate one important point right now, that you have heard about myoepithelial cells. So usually in case of a benign lesions, okay, the myoepithelial cells are present. But if you go towards a malignant lesion, okay, there is absence of myoepithelial cell. So this concept, we already know about that in detail, okay, and we are going to apply this particular concept over here. So first of all, try to understand when we are reading about a papillary lesion, most such lesions usually they are arising from a duct. So for example, this is a particular duct, okay, and over here, for example, one papillary arborizing lesion, okay, has basically started like this, okay. So this is your, basically this is the papillary lesion or the papillary frond, okay. This is the papillary frond or the papillary lesion that we see. And this is the duct from which it is arising. Yes, this is the duct or the periphery, or this is the duct from which the papillary lesion is arising. So one very important point that we have to see in any such immunohistochemistry that we are carrying out for such lesions, we are looking at the presence of myoepithelial cells at two places. The number one place is within the papillary frond. So number one, we are going to see the presence or absence of myoepithelial cells within the papillary frond or within the papillary lesion within the duct, okay, and this is the surrounding duct, okay. So this is the duct, and secondly, we see the presence of myoepithelial cells, okay. We will check for the presence of myoepithelial cells at the periphery of the lesion. So this is the periphery, okay. So always remember, these two things are very important for differentiation between such lesions, okay. So we are going to check for the presence of myoepithelial cells. So there are several markers for the myoepithelial cells like P63, calponin is there, okay, SMA is there, SHMHC is there. So there are many markers. I will discuss that in the later half of the video, but right now you just need to understand that how we can classify the lesion on the basis of demonstration of myoepithelial cells, okay. So now we are going to just see this before we go into the main video. So first, for intraductal papilloma, if you see, so this is basically the duct, okay, and over here this is the papilloma, for example, okay. So in case of an intraductal papilloma, remember the myoepithelial cells will be positive inside the lesion, the myoepithelial cells will be positive at the periphery as well, okay. This is classical of papilloma. If we are looking at the papillary ductal carcinoma in situ, okay, so over here this is a duct, okay, and there is a lesion over here, okay. So over here, what is happening, that in case of papillary ductal carcinoma in situ, the myoepithelial cells inside the papillary lesion is negative, okay, whereas the myoepithelial cells on the outer aspect is positive, okay. The myoepithelial cells in the periphery is positive, but the myoepithelial cells in the center is negative, okay. Then we are looking at the encapsulated papillary carcinoma. So in case of encapsulated papillary carcinoma, if this is the duct, okay, and over here you have the papillary lesion. So over here, what we are going to see, that the myoepithelial cell will be negative both in the lesion as well as they will be negative outside as well. But one important thing over here that you have to understand, though the myoepithelial cells are absent in the center as well as in the periphery, but the lesion is characteristically, it is encapsulated, okay, it is within a fibrous tissue. So that is why the term encapsulated papillary carcinoma. Now, in case of solid papillary carcinoma, it can be both in situ as well as invasive. The invasive variety is very rare. Okay, so the solid papillary carcinoma in situ, if you see, it is going to completely fill up the entire duct. Okay, and the papillary, the fibrovascular codes, they are visible. Okay, but they are they are actually very less visible because the entire lesion is actually covered by this particular lesion. So I will discuss in detail, but right now you need to understand that the myoepithelial cells can be present or absent, and they can be present or absent at the periphery, as well as they can be present or absent inside the papillary lesion. And in case of invasive papillary carcinoma, as we know, so basically these are invasive. Okay, so basically all the cells are invasive, so you will find fibrovascular cores, and they are infiltrative in nature. Okay, and over here the myoepithelial cells will be negative. Okay, it will be negative both at the center, both at the periphery. Completely it is negative, but they have an infiltrative or invasive growth pattern. So this is how we are basically differentiating between the different papillary lesions. Now this is a very basic concept. Okay, so as we are going to go further, we will understand in details how to differentiate them histologically as well. So with this concept in your mind, let us begin today's topic of discussion. So first, the basics of the papillary lesions of the breast. If you see, the papillary neoplasms, they are composed predominantly of papilla, each of which is consisting of a fibrovascular core covered by epithelium with or without a myoepithelial layer. So as I told you, some of the lesions, they are containing myoepithelial layer, some of the lesions are not containing myoepithelial layer. Okay, so with or without the presence of myoepithelial layer, depending on the type of papillary neoplasm that you are dealing with. The nature of the epithelium determines whether a papillary neoplasm is benign, whether it is atypical or it is malignant. So the assessment of the epithelial atypia is facilitated by considering the space between the adjacent fibrovascular cores as equivalent to the duct space and applying the criteria used for the interpretation of intraductal proliferation. So very importantly, what they are saying, if this is one fibrovascular core, this is another fibrovascular core, and over here the epithelial lining proliferation is there. So this space between the two fibrovascular core should be equated with a ductal space. Okay, what we see in other normal ductal lesions or ductal proliferations. Okay, so this is for all practical purpose. Remember, a cutoff of 3 mm is used to distinguish atypical ductal hyperplasia and low-grade ductal carcinoma in situ in case in a papilloma. So always remember that sometimes papilloma, so for example, this is a lesion, this is a papilloma. Okay, papilloma is a benign lesion. Sometimes in a papilloma, you can see certain areas, okay, of DCIS or certain areas of atypical ductal hyperplasia. Okay, so depending on the nature of the epithelial proliferation and depending on the nuclear characteristics, there can be certain focal areas of DCIS and ADH. Okay, so for such lesions, depending, so what is the cutoff? So if all such features are present and if the size is less than 3 mm, then we label it as ADH. Okay, ADH. So we will say a papilloma with an ADH. But if the size of the atypical proliferation is more than equal to 3 mm, then we are using the term DCIS. Okay, so we will say papilloma with a DCIS. Okay, so most papillary neoplasms, they are confined within the ducts, which tends to distend and become cystic with a thick fibrous wall. The intraductal papillary neoplasm of the breast, they include papilloma accompanied by atypical ductal hyperplasia and DCIS, papillary DCIS, and solid and encapsulated papillary carcinoma in situ. Okay, so these are all the intraductal, that is, these are confined within a particular duct. Okay, so we are using the term intraductal. Okay, these are intraductal papillary neoplasm. All benign intraductal papillary neoplasms, they will be surrounded by a continuous layer of myoepithelium, but the presence and distribution of myoepithelial cells along the papilla and at the periphery of the malignant lesions, they vary according to the lesion type. So as I told you, all the benign entities will show presence of myoepithelial cells both at the center as well as in the periphery, but the malignant lesions will have some variations depending on the type of the lesion that we are going to discuss in detail. Okay, papillary lesions completely devoid of myoepithelium, they include invasive papillary carcinoma and most encapsulated and solid papillary carcinomas. The latter may have few scattered and focal residual myoepithelial cells. That means in case of an invasive papillary carcinoma, both at the in the lesion and at the periphery, you will not find any myoepithelial cell. But in the encapsulated and solid papillary carcinomas, you may find little bit or in the periphery, some amount of residual myoepithelial cells can be seen. Okay, but in case of an invasive papillary carcinoma, no myoepithelial cells will be seen. The myoepithelial cells may be sometimes difficult to visualize by histopathology. So in such case, we make use of immunohistochemistry. So by IHC, what are the markers that we use? P63, smooth muscle actin, okay, smooth muscle myosin heavy chain, as well as calponin. So these are some of the myoepithelial markers that we are using. Okay. Just one important thing, these are the myoepithelial cell marker. Okay. Now, myoepithelial cell, they are also stained by certain other keratins, which we call it as high molecular weight keratin. What are those? For example, CK5, okay, CK14, these are high molecular weight keratin, and they are also going to highlight the myoepithelial cells. Okay, always remember this point. Okay. So the first important lesion that we are going to discuss right now is intraductal papilloma. So we have already seen, if this is a lesion over here, this is a papilloma over here. So the myoepithelial cells will be present both inside the lesion as well as in the periphery of the lesion. So at both the places, the myoepithelial cells will be present, and this is a completely benign entity. So intraductal papilloma, it is a benign breast lesion arising within a duct in a central or peripheral location. That means if this is the breast, it can arise either at the center of the breast, or it might arise in any of the four quadrants. Okay, so those arising at the center, they are called central papillomas, and those arising at the peripheries are called peripheral papillomas. Okay, and these lesions are composed of papillary projections with fibrovascular cords covered by epithelial and myoepithelial layers. So for example, this is a fibrovascular core containing blood vessels. So they will have the lining of epithelial cells, and at the base you will have the lining by the myoepithelial cells as well. Now, intraductal papillomas may occur centrally in large ducts near the nipple, or peripherally in smaller ducts in any of the quadrant that I already discussed. Now remember, there are certain differences in papillomas arising from the central or from the peripheral area. So what are the differences? Let us try and understand. Central papillomas, they present most frequently with unilateral clear or serosanguinous nipple discharge. Presentation as a palpable mass is less common. Peripheral papillomas, on the other hand, are usually clinically occult, or they are silent, but they can rarely present with nipple discharge, or even less often with a mass resulting from a small cluster of papilloma. Intraductal papillomas, with or without atypia, they account for around 5% of the benign breast biopsies. Most papillomas, they are arising from the central quadrant, and the patients presents over a wide age range, but most are between 30 to 50 years of age. The benign papillomas, these are monoclonal proliferation, that is, they will have certain mutations, especially in the PI3K-AKT pathway. Okay, and they are frequently identified in benign papillomas with or without hyperplasia. Loss of heterozygosity on 16p was found in benign papillary lesions as well as papillary carcinoma, whereas loss of heterozygosity at 16q was found only in the malignant papillary lesions. Okay. So let me just show you. So this is a very simple diagram. Okay, usually the papillomas, they are more large. So this is a very small papilloma that we can appreciate over here. So I just wanted to show you. So if you can see, this is a basic duct from where the papilloma, this is the stalk, and this is the papillary lesion, okay, that we can appreciate over here that has arisen. Okay, now very importantly, we can see both inside the myoepithelial cells will be present, and you can see on the outer aspect also surrounding the duct at the periphery also the myoepithelial cells are present. So the macroscopic appearance, if you see, the central papillomas may form well circumscribed round tumors of papillary front attached by one or more pedicles. This is the pedicle, and where they are attached to the wall of the dilated duct. So this entire thing is the duct. Okay, and basically they are arising from the wall of the duct. Okay, so the papillomas, they are arising from the wall of the duct. The size of the central papillomas varies from a few millimeters to more than 5 millimeters. Focal necrosis or hemorrhage may be present, particularly in larger lesions. In contrast, the peripheral papillomas, if you see, they are grossly occult or silent. Coming to the histopathology. Now papillomas can occur in various forms. So you might just come across a papilloma NOS, so only a papilloma is present, or along with the papilloma, in the papillomatous growth, you might see areas of ADH or DCIS. So how do we differentiate? When the lesion is less than 3 millimeter, we will call ADH. When the lesion is more than equal to 3 millimeter, we will use the term DCIS. Okay. Then we can have papillary DCIS also. Okay, so we are going to discuss each and everything in detail right now. The first important thing is the intraductal papilloma NOS. So both the central and the peripheral papillomas are characterized by cohesive but arborizing. Arborizing means like a network. Okay, this is arborizing. Arborescent structure composed of fibrovascular cores covered by a layer of myoepithelial cells with overlying epithelial cells. So over here, the epithelial cells are lined by the myoepithelial cells. So the lesion itself is containing myoepithelial cells. Not only that, the periphery of the involved spaces is also surrounded by the myoepithelial cell. So it is M plus M plus. So the lesion is positive for myoepithelial cells. The periphery is also positive. Okay, so it is a benign lesion. So the myoepithelial cell, which is always present, may be inconspicuous in certain lesions, and therefore in that case we are using combination of myoepithelial markers. Okay, what are those? So these markers are P63, calponin, and smooth muscle myosin heavy chain or SMA can be used as well. Along with that, these are some of the high molecular weight keratins which also stain the myoepithelial cell, that is CK5 and CK14. Okay. The epithelial component may consist of one layer of cuboidal to columnar cells or may show usual ductal hyperplasia. So very important thing is that in a papilloma, usual ductal hyperplasia is acceptable. So some of the epithelial cells lining the fibrovascular core might show UDH. Okay, so that is acceptable. And this area of UDH is also positive for CK5 or 14, and they are positive for ER, but the ER staining is heterogeneous and non-uniform. So one important thing I want to just remind you now only, in case of all the benign lesions, okay, or the papilloma that we are coming across, they will be positive for ER, but the ER staining pattern will be quite heterogeneous. It will be heterogeneous and the staining is patchy. Okay, whereas in any area, okay, that is containing malignancy, so any malignant areas, okay, for example an area of DCIS or an area of carcinoma, they will show strong and diffuse positivity for ER. So the ER positivity will be strong and diffuse. So this is one very important point of difference between benign and malignant lesion or atypical lesions. Okay, so remember this point very importantly. Now, apocrine change is sometimes found in the epithelium of papillomas and may be associated with diminished myoepithelium. Squamous metaplasia may also be seen, most often in association with areas of infarction. Now, ducts in the region of the papilloma often show dilatation or ectasia. Areas of hemorrhage or infarction may arise after a needling procedure or due to torsion of fibrovascular cord. Now, depending on the histopathological context, so there can be differential diagnosis for a papilloma. They are, so basically, what are the differential diagnosis? So all the entities in the papillary lesions, they are forming differential diagnosis for each other. So you will be questioned on that particular aspect. So what are the differential diagnoses over here? We are having intraductal papilloma, which is also having ADH and DCIS, okay, or papillary DCIS or intraductal papillary carcinoma, encapsulated papillary carcinoma, solid papillary carcinoma, and tall cell carcinoma with reverse polarity, nipple adenoma, and sweat gland hydroadenoma papilliferum. So these are all the important differential diagnoses of a papilloma. Now, under the heading of papilloma, now sometimes if you see, you can see this is a papilloma. Okay, this is a region, this is the ductal lesion. So over here you can see a very well defined papilloma region. Okay, a papilloma is there. Now there can be associated, along with that you can have associated DCIS or atypical ductal hyperplasia as well. Okay, so this is called as an intraductal papilloma with ADH or DCI. So there are focal areas showing features of DCIS or ADH. So what is going to happen over here? Very importantly, you have to remember in those areas which are typically resembling the papilloma areas, they will be showing the presence of myoepithelial cells inside as well as outside. Whereas those areas, okay, which are having more atypical areas, they might or might not be positive for myoepithelial cells. So they will show attenuation or decreased staining of the myoepithelial cells. So remember this point, okay. Foci of ADH or DCIS may be seen in papillomas, more commonly in peripheral than central papilloma. Papillomas with ADH and DCIS are characterized by focal population of monotonous cells with cytological and architectural features of low-grade ductal neoplasia. Myoepithelial cells may be scant or absent. That is why I have given plus minus from these foci showing ADH or DCIS. And the atypical epithelial cells, they are usually showing lack of staining for the high molecular weight keratin like CK5 and 14. with a uniform positivity for ER. So as I told you, so any atypical or any area which is going towards malignancy, they will show more strong and uniform ER positivity, okay, and they will show absence of myoepithelial markers. Now, the extent and the proportion criteria have been used to differentiate ADH from DCIS within a papilloma. So, as I told you, the cutoff is 3 millimeter. Okay, the atypical population, if it is less than 3 millimeter, we are using the term ADH. If it is 3 or more than 3, then we are using the term DCIS. Okay. When the epithelial proliferation with intermediate or high nuclear grade are seen, the diagnosis of DCIS within a papilloma should be made regardless of the extent. Now, for example, okay, if for example this epithelial proliferation that you are watching, and if you see a DCIS in a papilloma, but the DCIS, the nucleus is of high grade, in that case we will not label it as papilloma with DCIS. We will straight away label it as a DCIS. Okay, we will straight away label it as a papillary DCIS. Now, papillomas with DCIS must be distinguished from the other lesions like the papillary DCIS and encapsulated papillary carcinoma. So, these are the next topics of discussion only. So, I am not discussing these points right now. Okay. Now, similar to how we are seeing ADH and we are seeing the ductal carcinoma in situ in association with papilloma. So, just like that, the papillomas can also show areas of ALH and LCIS. Okay. So, what is the prognosis and prediction? Benign central papilloma without surrounding atypical change is associated with a twofold increase in the risk of subsequent invasive breast carcinoma. This risk is threefold with peripheral papillomas. With atypical papilloma, the risk of subsequent invasive carcinoma was around 5 to 7.5 fold. So, you have to know the prognosis, okay, and the relative risk of subsequent carcinoma that can occur. So this is basically a papilloma. As you can appreciate, there is a complex arborizing pattern and you can see the fibrovascular codes. Okay, you can see the fibrovascular codes. So you can see this is the duct space where they are contained. Okay, and this is the papillary lesion that we are appreciating over here. Okay, so if you see over here, and they are lined by two layers of cell, one layer of epithelial cuboidal columnar cell and another layer of myoepithelial cell. So this is a characteristic feature of a papilloma. The next important lesion that we are going to discuss in detail is the papillary ductal carcinoma in situ. So again over here, as I was telling you, so what is going to happen in this DCIS lesion? So you have a neoplasm over here which is basically atypical proliferation. So the myoepithelial cells are negative. They are negative, whereas the myoepithelial cells at the periphery or at the outside, they are positive. They are positive. Okay. Also, if you see in this lesion, the ER positivity is strong plus diffuse. They will show strong and diffuse positivity, okay, in this particular case. So papillary DCIS is a morphological subtype of DCIS, okay, composed of arborizing fibrovascular codes lined by neoplastic ductal epithelium which are devoid of myoepithelium and which are present in a central or a peripheral duct which is having retained myoepithelium at the periphery. So the lesion, they are negative for myoepithelial cells, whereas the periphery is positive for the myoepithelial cell, as I already explained it to you. Papillary DCIS is usually associated with DCIS having other architectural patterns, okay, and it may involve central or the peripheral ducts, okay. So those which are occurring in the peripheral ducts, they tend to be more clinically silent. It has been reported that papillary DCIS accounts for 3% of all the ductal carcinoma in situ. Papillary DCIS tends to be more common in postmenopausal women and is also the most common type which is seen in case of males. So the most common DCIS seen in males is papillary DCIS. Now they show the same genetic alterations like DCIS in general that we have already discussed, okay. So macroscopically, again, the gross appearance of papillary DCIS in a subareolar location is difficult to distinguish from that of an encapsulated variety, and the two lesions might coexist as well. So the definitive diagnosis will be based out of histology and by carrying out immunohistochemistry. So looking at the histopathology, they consist of intraductal. Again, the lesion is within a duct. Intraductal neoplastic epithelial proliferation which is lining arborizing fibrovascular codes which are devoid of myoepithelium. So inside, the myoepithelial cells are absent completely. Okay. So very important, but on the outer aspect, remember, on the outer aspect, remember the papillary DCIS, they are showing an intact myoepithelial layer at the epithelial stroma interface of the periphery of the infold duct. The epithelial proliferation may partially or completely fill the space between the papilla, creating many different architectural patterns, like a solid pattern can be there, cribriform pattern can be there, micropapillary, spindle, compact columnar. So many architectural patterns can be there, but along with that, the underlying basic papillary architecture will be preserved. Papillary DCIs often constitute one of these several architectural patterns in a case of a DCIS. But compared to the other types of DCIs, if you see papillary DCIs, they are less commonly associated with comedonecrosis. Like all types of DCIs, papillary DCIs is graded on the basis of nuclear atypia. Although most papillary DCIS lesions consist of single uniform cell population, papillary DCIs with a dimorphic pattern has been described. In addition to the neoplastic ductal cells, it will feature a population of globoid cells with abundant clear cytoplasm, and these cells morphologically resemble myoepithelial cells, but if you carry out IHC, these will be negative for myoepithelial marker. They resemble the myoepithelial marker, but they are not myoepithelial marker. Solid papillary carcinoma in situ, it is a special subtype of papillary DCIs. Okay, remember, the solid papillary carcinoma in situ, it is a special subtype of papillary DCIs. The differential diagnosis, again, as I told you, will be other lesions, okay, which are across the spectrum of the papillary lesions of the breast, like papilloma, papilloma with atypia, encapsulated papillary carcinoma, solid papillary carcinoma, etc. Now, immunohistochemical staining for myoepithelial antigens, the high molecular weight cytokeratins, ER and neuroendocrine antigens may be used to distinguish between these lesions. Low grade and intermediate grade lesions typically show diffuse nuclear positivity for ER and no expression of CK14 or 5-6. These are basically highlighting the myoepithelial cells. So they will be absent, but diffuse positivity for ER is seen in the epithelial proliferation areas. Okay. So this is what I wanted to tell you. This is what a papillary DCIS looks like. So this is the particular lesion that we can see. A monotonous lesion is there. Okay, so inside the myoepithelial marker is negative. So we have used P63 over here. Whereas at the periphery, if you see, the P63 positivity is there. Okay. This is basically the papillary carcinoma DCIS. As I told you, the papillary DCIS can have a solid component also. So for example, this is the solid variety of papillary DCIs. Why we are saying papillary? Because some blood vessels can be appreciated and fibrovascular course is retained over here. So over here also, if you can see in the lesion, the myoepithelial cells, they are absent. The P63 staining is negative. Whereas in the periphery, as you can appreciate, the P63 staining is positive in the periphery. Okay. Okay. Now we are going to read about the encapsulated papillary carcinoma. So what will happen over here? So the lesion is encapsulated completely. So within whatever lesion is there, okay, the myoepithelial marker will be negative, and outside also in the periphery also the myoepithelial marker will be negative. This is very important to understand. This is the encapsulated papillary carcinoma. So the encapsulated papillary carcinoma is a carcinoma characterized by fine fibrovascular stalk covered by neoplastic epithelial cells of low or intermediate nuclear grade, typically present within a cystic space and surrounded by a fibrous capsule. Now, these are there are usually no myoepithelial cells, not in the papilla, neither in the periphery. At both locations, they are absent. Most tumors are central and subareolar. The lesion presents as a circumscribed round mass with or without nipple discharge. Encapsulated papillary carcinoma, they tends to be larger at presentation with a cystic growth pattern. Usually they occur in postmenopausal women, mainly during the 7th decade of life, and the genomic features are similar to those of low-grade ER positive of no special type, that is like luminal A variety only. For example, 16q loss, 16p gain and 1q gain is seen. The prevalence of PIK3CA mutation is similar to that in ER matched and grade matched IBC or invasive breast carcinoma, no special type. The PAM50 subtyping classifies majority of the cases as the luminal A type and minority can be luminal B. So macroscopically, they appear as a friable mass within a cystic space. So this is very much similar to a papillary DCI. So you cannot differentiate based on the gross features. So histologically, as I told you, you will see a papillary mass within a cystic space, a ductal lesion. Less often it is composed of an aggregate of closed nodules. The tumor has a rounded pushing border and typically surrounded by fibrous capsule of varying thickness. So though the myoepithelial cells are absent at the periphery, but the lesion is very well surrounded by a fibrous capsule. That is why the term is encapsulated, okay, encapsulated papillary carcinoma. The lesion consists of multiple delicate fibrovascular stalk covered by a monomorphic population of neoplastic cells with low or intermediate grade nucleus. These cells are arranged in single or multiple cell layers, and they can also form micropapillary or cribriform structures that fill the gap separating adjacent papilla. There are typically no myoepithelial cells, not inside the lesion, not in the papilla, neither they are present at the periphery. At both areas they are absent. Now remember, such lesions, they can have a frank invasion, okay? So frank invasion in this setting is defined as the presence of the neoplastic elements that permeate beyond the capsule. So for example, if the lesion inside, they start to come out. So in that case, okay, in most cases, they take the form of invasive breast carcinoma NST. The neoplastic epithelial component does not express high molecular weight keratin, as I told you, and they will only show the presence of strong and diffuse ER positivity will be there, and all myoepithelial markers will be negative. Okay, remember this point. The differential diagnosis, as I told you, all the papillary lesions are differential diagnosis for each other, so you can write this point there as well. Now, in the absence of associated areas of infiltrating carcinoma, if there are no areas of infiltrating carcinoma, then encapsulated papillary carcinoma has a very favorable prognosis. In very rare instances, lymph node metastases have been reported, with the metastasis revealing typical papillary features. Now, the presence of associated ductal carcinoma in situ in the adjacent breast tissue confers a higher risk of local recurrence. Lesions presenting with a growth pattern similar to that of encapsulated papillary carcinoma, but with nuclear pleomorphism and increased mitotic activity, or a triple negative or a HER2 positive phenotype, should be staged, graded and managed at IB. So any encapsulated papillary carcinoma with a high grade nucleus or triple negative phenotype or a HER2 positive phenotype, they should be managed as an invasive breast carcinoma. Now, this is basically what I want to tell you. So you can see this is the papillary lesion, and if you see over here, this is the periphery. So both at the center, myoepithelial cells are negative. Both at the periphery, they are negative. So over here, we have used the CK14 high molecular weight keratin to highlight. Okay. Now over here, if you look at the ER positivity, as I told you that in the malignant areas or in the carcinoma areas, the atypical areas, they will show strong and diffuse positivity. So you can see this is the strong and diffuse positivity of ER that we can appreciate in this particular diagram. Now, solid papillary carcinoma. Now, try to understand something about the solid papillary carcinoma. Solid papillary carcinoma, first of all, it can be both types. It can be in situ, which is the most common, more common variety, and it can present as an invasive solid papillary carcinoma, which is very, very rare. It is ultra rare. Okay. So, what is very important over here, you are going to get a lesion. Okay, and you will see that the entire lesion are composed of these solid cluster of cells. In between, the fibrovascular pores are there. Okay, so what is very peculiar about this lesion, that this is most importantly, this is a histological diagnosis than a IHC diagnosis. So over here at the center of the lesion or in the lesion, the myoepithelial cells may be present, may not be present. So the staining might be positive, might not be positive, and even at the outside it is the same thing, plus minus. Okay. So one very important thing over here is there is an encapsulated or the lesion is mostly in situ. In very rare cases, it can be invasive. So solid papillary carcinoma, they are tumors characterized by a solid growth pattern, but the background is comprising of delicate fibrovascular core. And very importantly, they show neuroendocrine differentiation, and they are biologically very slow growing tumor. That is why it is important to understand and to recognize these lesions. Any part of the breast may be affected, but the central or the subareolar area is affected most commonly. Solid papillary carcinoma may present as a palpable breast mass, a mammographic abnormality, and or as a bloody nipple discharge. Now, solid papillary carcinoma occurs primarily in postmenopausal women and mainly during the 7th decade of life or later. Macroscopically, gross examination will show soft, well circumscribed tan pink mass. Now, histologically, it is characterized by the presence of multiple expansile nodules like this, okay, with a solid growth pattern and inconspicuous delicate fibrovascular core in the background. The proliferation is composed of monotonous population of round to spindle-shaped epithelial cells with mild to moderate nuclear atypia and a variable mitotic count. These cells have eosinophilic granular cytoplasm and may contain mucin vacuole. So very, very important. The round to spindle shaped epithelial cell nature, this very low grade with very mild nuclear atypia is there. So the features are very, very bland. This is what I'm trying to tell you. Signet ring cell features may be prominent. Nuclear palisading around the fibrovascular core is common. Extracellular mucin production can also be present, but if it is prominent, mucinous carcinoma must be excluded. Solid papillary carcinoma in situ is diagnosed when the nodules have rounded, well circumscribed contours and a distribution pattern which is consistent with an in situ process, and this is regardless of the fact whether myoepithelial cell is present at the periphery or no. So over here you have to have a solid pattern and expansile pattern. Now I don't care whether myoepithelial cells are present inside, outside, anywhere, but if you have such histological feature and if you see that there is no frank invasion, all of them are basically surrounded by a fibrous capsule, in that case we will use the term solid papillary carcinoma in situ. Okay, but the nuclear features has to be very mild, okay, very bland. Solid papillary carcinoma with invasion is diagnosed when a solid papillary carcinoma is associated with a mucinous carcinoma. So sometimes you might have areas of solid papillary carcinoma. So these are areas of solid papillary carcinoma in situ. Okay. Along with that, you might have certain areas of containing mucin. Okay, and in the mucin, you might see the areas, the mucinous cells or the epithelial cells. They are basically floating in the islands of mucin. So this is a solid papillary carcinoma, which is associated with a mucinous carcinoma. So this can be seen, this can occur, okay. But very importantly, what is more important is the fact the invasive component may also be of a more conventional type. So what we are trying to say that the solid papillary carcinoma in situ can occur with another carcinoma, most commonly mucinous carcinoma, but there can be other types of carcinoma like carcinoma of no special type, lobular, cribriform, tubular. So it is occurring in association. Now sometimes, okay, very rarely this solid lesion or this solid papillary carcinoma in situ is going to invade. So in very rare instance, the solid carcinoma may show features of invasive disease. That in that case we call it as an invasive solid papillary carcinoma, that is diagnosed when the nodules are devoid of a myoepithelial cell layer and they have a very ragged contour. So the contours are quite ragged, creating a geographical jigsaw pattern within a desmoplastic stroma. So the nearby stroma has also become desmoplastic. Okay, so this is an invasive variety and it is very rare. Now the neoplastic cells, they lack expression of the myoepithelial markers like the high molecular weight keratin, and they are strongly and diffusely positive for ER. They do not show HER2 positivity. The Ki67 index is usually low or intermediate. One very characteristic feature of the solid variety is they show presence of neuroendocrine differentiation, which is not shown by any other papillary neoplasm. Okay, it is demonstrated by the synaptophysin or chromogranin expression. It is frequent in particular when there is an associated mucinous component. Papilloma with florid UDH that completely obliterates the spaces between papillae can be mistaken for solid papillary carcinoma. In such cases, the fibrovascular cores are typically broad with a prominent stromal component, and the proliferating cells are less monotonous and they have more irregular nuclei. And not only that, they will show presence of myoepithelial cells in case of papilloma with florid UDH. Okay, whereas over here it may be or may not be present. Now the hyperplastic epithelial cells in a papilloma, okay, as I was telling you, the hyperplastic epithelial cells, they will express the myoepithelial markers like high molecular weight keratin, CK5, CK14, and the staining for ER will be more patchy. It is not strong and diffuse. So that is going to help us to differentiate. Okay, whereas the neoplastic epithelial cells of solid papillary carcinoma will lack the myoepithelial markers, or they will be negative for the high molecular weight keratins, and typically they will show strong and diffuse ER positivity. A myoepithelial cell layer is present along the fibrovascular cores and at the periphery of the lesion in case of a papilloma, that we have already seen. So why is it important to recognize and why they are a separate entity? Because they have an excellent prognosis. Okay, so as you can appreciate, this is a solid variety. Okay, so you can see that this is completely filling up the space. Okay, and this is a solid papillary carcinoma in situ. So they have expanded and dilated ducts that are partially filled by a solid monotonous epithelial cell population punctuated by multiple vessels or the codes in the background, as we can appreciate over here. This is the high power view where we can see, can you see this fibrovascular core? So in the high power view, you can see, if you go higher, you will see that the population of cell is quite monotonous. You are either having a round or spindle shaped like this cells are there. They have very bland nuclear morphology. Okay, so this is very important to understand. Now lastly, this is a very rare lesion. WHO says that it is such a rare lesion that even the epidemiology and the prognosis is not known yet. Okay, so invasive papillary carcinoma, it is an invasive carcinoma with fibrovascular cores covered by neoplastic epithelium. The lesion is extremely rare and no specific epidemiological or clinical data is available yet. So they display a frankly invasive growth pattern and are composed of mildly dilated ducts and microcysts containing papillary formation. Myopithelial cells, as expected, will be absent in the periphery as well as from the lesion. Now they are graded according to the Nottingham grading system. So I hope you remember, okay, what is that system of grading? These tumors should be differentiated from invasive micropapillary carcinoma and metastasis to the breast. Invasive micropapillary carcinomas, they have a distinctive growth pattern characterized by cluster of cancer cells that lack fibrovascular core. So this is about the micropapillary variety, okay, and surrounded by clear stromal spaces. And metastasis of the ovarian or papillary adenocarcinoma like the pulmonary and the thyroid, so they can be distinguished from breast by using IHC like the TTF, napsin A, okay. So these markers can be used, or WT1, PAX8, CK7, they might be used to differentiate such lesions with the help of immunohistochemistry. So we have completed all the discussion, and in the end, if you have understood what I have taught you, so you just have to remember this chart for your exam. So what are the lesions that we are going to compare and contrast? The intraductal papilloma, that with ADH DCIS, papillary DCIS, encapsulated papillary carcinoma, solid papillary carcinoma, invasive papillary carcinoma. So in the papilloma, as we know, myopithelial markers, what are those? P63, CK14, SMA, or smooth muscle myosin heavy chain, calponane. So all these markers, okay, we are going to compare first in the lesion, that is in the papillary lesion, and then at the periphery. If you see over here in the intraductal papilloma, myopithelial cells are present both in the lesion as well as in the periphery. If you look at the high molecular weight keratin, CK5, 6 and CK14, they are positive in the myopithelial cells, okay. So they are showing heterogeneous positivity, and the ERPR, if you see, they are having a very patchy positivity, okay. They are having a patchy positivity over here. Now, those papilloma which are involved by ADH and DCIs, now one very important thing is that the myopithelial markers are positive completely in the papillomatous area, okay, as well as in the periphery they will be positive, but in the areas containing ADH and DCIs, they are scant or they are reduced, okay. So this is very important point. High molecular weight cytokeratins, they will be positive and they will be highlighted by the myopithelial cells. Remember, this myopithelial markers, they will be negative, okay. This high molecular weight cytokeratin will not be there in the ADH or DCIS component, just like the myopithelial cell marker. Very important that there will be patchy staining. So in all the papillomatous portion, if you see, they will show patchy positivity for ER, but the ADH and the DCIS areas will show strong and diffuse positivity for the ER. Papillary DCI is very easy. In the lesion, negative myopithelial. Outside the lesion periphery, they will be positive. If you look at the high molecular weight keratin, again it is same. It will highlight the myopithelial cells and they will be negative in the neoplastic population, whereas the neoplastic population will show strong and diffuse positivity for the ER. Encapsulated variety, the myopithelial cells will be absent both in the lesion, both outside, okay. They are also negative for high molecular weight cytokeratins, and they will show, the neoplastic area will show strong diffuse positivity for ER. Solid variety, as I told you, the lesion may not or may be positive for myopithelial markers at the both at the lesion, both at the periphery. Again, over here, the high molecular weight cytokeratin, they are negative in the lesion, whereas the neoplastic area, they will show strong and diffuse positivity for ER-PR. And invasive papillary carcinoma, as I told you, everything will be negative at all the places. Only the ER-PR will show strong positivity and they will have an infiltrative growth pattern. So with this, I have completed this particular session. Please note that this is a very, very important exam slide. Thank you very much for watching this particular video.